Here is a comprehensive article on uveitis in rheumatology, suitable for teaching, publication, or reference purposes. Title: Uveitis in Rheumatology, Clinical Significance, Associations, and Management. Uveitis, defined as inflammation of the uveal tract, iris, ciliary body, and choroid, is a significant extra-articular manifestation of various rheumatologic disorders. Rheumatologists must recognize the clinical spectrum, systemic associations, and therapeutic options for uveitis to ensure early diagnosis and prevent vision loss. This article reviews the types of uveitis, its rheumatologic associations, diagnostic approach, and current treatment strategies. Introduction. Uveitis represents a heterogeneous group of intraocular inflammatory conditions that can be sight-threatening if not promptly recognized and treated. It may occur in isolation or in association with systemic autoimmune or autoinflammatory diseases. Rheumatologic disorders are among the most common systemic associations, especially in cases of chronic or recurrent uveitis. Understanding the rheumatologic implications of uveitis is crucial for early systemic evaluation and multidisciplinary management. Classification of uveitis. Uveitis is classified based on anatomical location, onset, duration, and course by location. Anterior uveitis involves the iris and/or ciliary body, iritis or iridocyclitis. Intermediate uveitis involves the vitreous, pars planitis. Posterior uveitis involves the retina or choroid. Panuveitis involves all parts of the uvea. By duration, acute, sudden onset, duration 3 months. Chronic, persistent inflammation 3 months. By course, recurrent, repeated episodes separated by periods of inactivity. Chronic relapsing, persistent inflammation with flares despite treatment. Clinical features. Symptoms depend on the site and severity of inflammation. Anterior uveitis, eye pain, redness, especially ciliary flush, photophobia, blurred vision, and tearing. Intermediate posterior uveitis, floaters, visual disturbances, or decreased vision with minimal pain. Systemic symptoms may precede, accompany, or follow ocular findings in rheumatologic diseases. Rheumatologic associations. 1. Spondyloarthritis, SPA, ankylosing spondylitis, AS. Acute anterior uveitis is the most common extra-articular feature. Reactive arthritis, psoriatic arthritis, IBD-associated arthritis, also associated with anterior uveitis. HLA-B27 is a strong genetic link. Up to 50% of HLA-27 plus patients develop uveitis. 2. Juvenile idiopathic arthritis, JIA, especially in oligoarticular JIA with ANA positivity. Often asymptomatic and chronic, can lead to cataracts, glaucoma, and blindness if unrecognized. 3. Behçet's disease, characterized by recurrent, bilateral, non-granulomatous panuveitis with retinal vasculitis, can be fulminant and lead to irreversible vision loss. 4. Sarcoidosis causes granulomatous uveitis, often bilateral. Other ocular features: lacrimal gland involvement, conjunctival granulomas. 5. Systemic lupus erythematosus, SLE. Uveitis is rare but may occur, more commonly associated with retinal vasculitis. 6. Vasculitis syndromes, granulomatosis with polyangiitis, GPA, can cause scleritis, episcleritis, and uveitis. Polyarteritis nodosa and other small vessel vasculitis, less commonly associated. 7. Other autoimmune autoinflammatory syndromes: Blau syndrome, juvenile sarcoidosis, relapsing polychondritis, Cogan syndrome. Diagnostic evaluation. 1. Ophthalmologic examination. Slit lamp exam determines sight and severity. Fundoscopy for posterior segment involvement. Optical coherence tomography, OCT, fluorescein angiography, or ultrasound B scan as needed. 2. Systemic evaluation. Detailed history, joint symptoms, mucocutaneous lesions, constitutional features. Laboratory workup: CBC, ESR, CRP, ANA, RF, anti-CCP, HLA-B27 typing, ACE level, serum calcium, sarcoidosis, tuberculin skin test or IGRA if TB suspected. 3. Imaging: chest X-ray or CT sarcoidosis TB, MRI sacroiliac joints, SBA. Management approach. 1. Local therapy. Topical corticosteroids, first line for anterior uveitis. Cycloplegic agents to relieve pain and prevent synechiae. 2. Systemic therapy. Systemic corticosteroids for posterior or refractory anterior uveitis. DMARDs, methotrexate, azathioprine, mycophenolate, especially in JIA, sarcoidosis, Behçet's. Biologics, anti-TNF agents, particularly adalimumab and infliximab, are effective for uveitis in SPA, JIA, and Behçet's. IL-6 inhibitors, e.g. tocilizumab, and IL-1 blockers, e.g. anakinra, in selected cases. 3. Surgical intervention for complications like cataract, glaucoma, or retinal detachment. Role of the rheumatologist. Recognize and evaluate systemic causes of uveitis. Collaborate closely with ophthalmologists. Monitor for systemic disease activity and therapy-related complications. Choose immunomodulatory therapy tailored to both systemic and ocular disease. Prognosis. Dependent on early detection, etiology, and control of inflammation. Chronic or recurrent uveitis increases the risk of complications, glaucoma, cataract, macular edema. Vision loss can be prevented in most cases with timely immunosuppressive therapy and multidisciplinary care. Conclusion. Uveitis is a window to systemic inflammation and often a heralding feature of underlying rheumatologic disease. Rheumatologists play a key role in the multidisciplinary management of patients with uveitis. Awareness of disease associations, timely systemic evaluation, and appropriate immunosuppressive therapy are pivotal in preserving vision and improving overall patient outcomes.